Awesome. Thank you so much, Amit, for the kind introduction. As I mentioned, I'm Karan. I'm very excited to be talking to you guys about Med-PaLM and the potential for large language models and their multimodal counterparts to help transform healthcare. Let's get started. So I'll kind of give a little bit of an overview of the space, talk a little bit about tasks and evaluation, about some of the models, experiments, and then I'll leave some time for open discussion. And then we'll talk about kind of conclusions. Let's get started with motivation here. So when we first started this project within Google, it started out as a kind of bottom-up brain moonshot, 4 of us kind of working on it together, proposing it to leadership and seeing whether we could kind of get started on the idea of exploring the idea of large language models catalyzing kind of a wider impact in medical AI. And so when we started, we really started thinking about 2 broad topics that we were interested in. One was kind of the potential for improved care delivery. And so for many years, there's been kind of a hype and excitement around the potential for AI in healthcare. And a lot of that has been centered around the potential for care delivery. And so, in the past, that's often looked like algorithms for improved diagnosis of certain conditions. For example, narrow AI models that take in an image and then perform some classification. And in the last several years, with the advent of deep learning, we've started to get to the point where these models have gotten performant enough and reliable enough that they can be deployed sometimes in real-world settings. And so there's been some exciting developments here. At the same time, there's also the area of scientific discovery, which maybe in the longer term could be a place where AI could have even more impact. So I'm personally of the belief that if AI goes really, really well, if increasingly general AI goes really well, that one of the places where it'll have the most impact is through advancing science. And so we've kind of seen this nascent field recently of kind of scientific discovery through AI, where people are doing things like drug discovery or kind of protein LLMs or genomic LLMs, and also kind of novel biomarker discovery. A lot of this is very recent, sometimes in the last year or two. I think there's a lot of exciting work to be done here. And I think what I'll kind of describe a little bit over the course of the talk is that I think work on training large-scale foundation models that are able to adapt to the setting might also be, one potential way that these models could be impactful in the real world. By the way, feel free to jump in anytime for any questions as well. Awesome. So I'll talk a little bit more about medicine and language, which is really where we started. We saw the current state of the medical AI field and noticed that a lot of existing models were kind of narrow medical AI systems that could, take in an image or some text and then produce some classification. But we noticed that language, enables key interactions between clinicians, researchers, and patients in the real world. And there's an incentive to kind of develop systems, especially in the short and medium term, that are kind of complementary and cooperative with the physicians of today. And so human and AI collaboration in the last few years has been emerging as like a key driver for a lot of the innovation in the space versus kind of models and of kind of integration that involve kind of replacing key workflows, which seem to not work as well. And so if we look on, at this figure, on the left, we have today's medical AI, which often looks like narrow classification tasks, basically given some context, produce some classification. In the middle, we have this complementary and cooperative model where, for example, a model might produce a classification, but then might defer to a radiologist, for example, if it's making a prediction. So there's been exciting work published on this in the last year. And then, at the end, one vision that we were motivated by with the Med-PaLM work was the vision of kind of a fully interactive system where it could be a physician's assistant, basically take in all the context that is needed from a patient and be able to kind of point out any kind of issues or anything of concern, and to be able to provide clinical decision support as well. And so we were very excited about that kind of potential, but saw that the existing models couldn't do that as well. At the same time, we also saw like a lot of exciting work going on in large language models for science and biomedicine. So all these works were before our original Med-PaLM work, and so there were a lot of exciting findings that we were seeing, at the same time, we did see kind of opportunities for us to contribute. And so at the time, there were a few things that we were excited by. The first was the potential to explore safety and steerability of AI systems in this setting. So in general, large language models produce hallucinations, unhelpful answers. They're often fairly unreliable, which really matters in high stakes settings like this. They can often kind of replicate or amplify biases or other kind of correlations that are present in their training data. And so there's kind of an open challenge in large language models in general around controlling this behavior. And in this setting, it's even more important to kind of make sure that these models are kind of behaving as you'd expect and align with the values of society, of physicians, of patients. And so that was kind of one of the motivating challenges behind us kind of looking at Med-PaLM. The second challenge was that there was no standard set of benchmarks for testing the clinical knowledge of large language models. And so at the time when we were starting to work on Med-PaLM, there was kind of a sense that it wasn't obvious how much medical knowledge that these models were kind of encoding. And then the last thing was kind of human evaluation. So especially in like a safety critical setting like this, we need to think carefully about human evaluation. And a lot of previous works had kind of relied on automated evaluation via either automated benchmarks or natural language generation metrics. And so we saw a real opportunity to kind of do careful human evaluation to get a better sense of whether or not there was progress being made and kind of to capture potential harms and then actually work on those potential harms. So I'll be talking a little bit about 3 papers, giving a very brief overview of Med-PaLM, Med-PaLM2, and Med-PaLM-M. And this was work done with a very large team of folks who are shown in this slide. And so this work would not have been possible without all these folks here as well. So on the tasks and data sets, I'll talk a little bit more about where we started, which was thinking about text-only tasks, including especially medical question answering. This was potentially multiple tasks that we could have started with summarization or clinical decision support or triage. We ended up tackling some of these tasks later, but at the beginning, for the first Med-PaLM paper, we really focused on medical question answering because we viewed it as kind of a fairly general task. Basically, given a question could be kind of a wide variety of things, whether it's multiple choice or long form answers and the kind of topic, and whether it's asking for a diagnosis or not, or whether it's asking a general question that's informational. So there's a kind of a wide variety of things that we want to be able to do under medical question answering. And answering medical questions reliably relies on comprehension skills, so whether the model is able to actually comprehend the question, recall of medical knowledge, and also manipulation of expert knowledge. Any questions so far? Cool. And so one of the main contributions of the initial Med-PaLM work was kind of curating this multi-med QA medical question answering benchmark, which involved 6 existing benchmarks that were both multiple choice and long form answers, and also the additional health search QA benchmark, which was commonly searched questions about health on the web. And in general, this kind of benchmark was motivated by a few things. One was we were interested in kind of going beyond kind of automated benchmarks like multiple choice accuracy or NLP generation metrics to go towards human evaluation. Second, we were also interested in kind of probing different aspects of medical question answering. And so this involves kind of open domain versus closed domain questions, or medical exams versus medical research and consumer questions. And also questions about biomedical research or about like consumer queries about their health and things like that. So there's a lot of kind of variety in these data sets, but there's also limitations, which I'll discuss a little bit later as well. Just to give a few examples of the kind of data sets that we were looking at. So on the left is health search QA. So these are kind of commonly searched questions on the web. In the middle, we have live QA. So these are questions that have been submitted to a service. And then there's some reference answers, which we didn't use for this work, but just providing an example here. And then on the right, we have Med-QA, which is kind of USMLE or US medical licensing exam style questions, which often look like a clinical vignette given a patient, given some of their context, answering some question about that context. And just providing a little bit more of a summary of the different tasks we had here and the format of the questions and also the domain of the different questions here. One other kind of evaluation kind of detail that we had was we did a human evaluation of the long form answers provided by these models. And so that involved us kind of coming up with a human evaluation framework for physicians to do and for lay users to do. And so for clinicians, our initial framework basically looked like this. It asks a bunch of questions to physicians. Given a question, given a potential answer, whether it's from a physician or from a model, we had these physician raters complete these questions. So things like whether or not the answer relates to scientific consensus, whether there's a high likelihood of harm or extent or severity of harm, whether there is comprehension, retrieval, reasoning being displayed, whether there's any inappropriate or incorrect content or missing content, whether there's any possibility of kind of implicit or explicit health equity bias. And on the lay user side, we asked a couple more questions about user intent and then the helpfulness of the answer to basically get a sense of whether lay users or consumers would find the answers to these questions useful or not. And then in terms of data sets we used, so we took the the data sets for multi-med QA that involved long form answers. For the Med-PaLM 2 paper, we also added additional adversarial questions, both general and in the health equity context. We did triple ratings of question answer tuples for each data set by clinicians to kind of get a sense of whether or not we could achieve good inter-rater reliability. And lastly, the final ratings were performed by 15 clinicians based in the UK, the US, or India. And we tried to select for a variety of kind of specialties and demographics in these ratings. Any questions so far?
Yes, I have a question, or I actually have a couple questions. So first, the providers or the evaluators, are they volunteers, or how were they identified? Because I think that might bring a little bit of bias to the evaluation, right?
It's a great point, and I'll bring it up later near the end of the talk as well around improving methodology.
Sounds good.
But I can quickly summarize here as well. We basically worked with paid clinicians who were basically paid for their services and also paid lay users. And so they were basically recruited by a vendor firm that we worked with, who basically handle rating tasks for us. And so then we worked with them to identify possible candidates and then to kind of make sure that we were getting good coverage of different locations and specialties and things like that. But there's obviously more work to be done here, and I'll mention that more at the end.
Sounds good. And the other, I don't know if it's a question or just a comment, that there's a lot of criticism, I'm going to call it, especially for large language models and the impressive performance that it has on tasks like answering the USMLE type of questions, because most of the time, or actually all of the time, that for multiple option questions, the correct answer is there, right? So it's I don't want to say cheating, but it's not completely predictive or generative, because the answer is there. It's not completely zero shot. I don't know how to call it. So, and I'm saying this because we're working right now on a project that uses LLMs, and that's kind of the criticism that we're getting, is like, how do you know that this is reliable? And in the USMLE setup, that it is, because again, you have the information there and one of the answers is the correct one. But what do you do when you have a more or a less constrictive environment?
Yeah, absolutely. So definitely the kind of the fact that a lot of existing work had been evaluating solely on multiple choice benchmarks was one of the motivators for our work as well. And so the protocol that we have briefly discussed here is kind of a way of evaluating the model's long form answers to questions beyond these multiple choice questions. So the data sets that we evaluated on, shown on the slide, live QA, medication QA, health search QA, and then these adversarial questions are all questions in which the answer choice, there's no answer choices. And so the model is doing like an open-ended generation to be able to produce an answer without the answer being shown to it. So that's one way of moving towards that. But there's also I think there's still additional limitations with this approach, where this is still not, fully in a real world workflow. And I'll talk a little bit more about that limitation towards the end as well.
Sounds good. Thank you.
Yep. Awesome. I'll also talk a little bit about the multimodal tasks that we did for the Med-PaLM paper. So we basically, for this paper, we added 11 additional tasks across different task types. So things like visual question answering, image classification, report generation, genomic variant calling. So kind of a wide span of kind of sources, from dermatology to chest X-ray to genomics, different modalities, so text, uh, different kinds of radiological images, genomics data, and also kind of different output formats, whether that's a classification or like a more open-ended generation. We kind of cover different things in this work as well. This slide also gives a brief summary of the different tasks and also the specific data sets used. There were 12 unique data sets here, and then 14 different tasks used. 3 were used also in the multi-MedQA benchmark as well. And lastly, for the multimodal evaluation, we also did a physician evaluation there as well. So again, not just fully relying on automated metrics. And so what we did here is basically have a reference report from the data set, in this case, the Mimic CXR data set, different versions of Med-PaLM, which I'll talk more about what Med-PaLM is later. And then we had radiologists basically rank different responses, both pairwise and across all the 4 different possible answers. And then I'll present some results on that a little bit later. Cool. I'll do like a brief overview of modeling, but this won't be the focus of my talk here. And so a little bit of context here. Med-PaLM obviously builds on PaLM, which is the Pathways language model, which came out last year. This is the largest, at the time, the largest densely activated decoder-only model, 540 billion parameters, trained using this large-scale ML system. We also had the FLAN-PaLM models that we built on for this work as well. FLAN refers to kind of the instruction tuning on top of PaLM. And so this is basically taking PaLM and then fine-tuning it on a certain format of data, which looks like here's an instruction, here is a task, and here's the answer to the task. And so it turns out that this is like a pretty strong baseline for basically getting models to follow instructions well. And so we built on this work, both in terms of building from the FLAN PaLM checkpoints, and also in terms of applying instruction tuning in different ways. Especially for the first Med-PaLM paper, we were motivated by exploring data-efficient strategies for better aligning the model with the requirements of the setting. And so on the left, we had prompting strategies, which is basically taking FLAN PaLM without doing any kind of updates at all, just prompting it in different ways, whether that's few-shot prompting or chain of thought prompting or self-consistency prompting. I'll briefly discuss these things as well. And on the right, we explored prompt tuning. So basically kind of simple, like computationally inexpensive tuning of certain parameters associated with the prompt of the model. And you can basically view this as like a learnable way of prompting the model because you're basically modifying the same parameters. Any questions so far? Awesome. So just to briefly touch on few-shot prompting, which is probably familiar to folks in this call. This is when you basically put in the prompt examples of the input-output behavior that you want, and then you ask it again, here's another input, and then it tends to be better at producing the desired output given that. This was first kind of explored pretty thoroughly in the GPT-3 paper. We also have chain of thought prompting, which is basically getting models to produce kind of explanations or chains of reasoning before they produce their final answer. And so that their final answer is then kind of conditioned on that chain of reasoning. And so the benefit here is that you are now able to get the model to kind of do smaller tasks or subtasks of answering a question before it does the final task. And empirically, across many tasks, this tends to perform well, especially across like reasoning and math types of problems, which at least prior to this work, large language models were pretty bad at. Another quick thing I'll give an overview of is self-consistency prompting. So you can view this as kind of building on chain of thought prompting. So the first thing you do is you prompt a model using chain of thought examples. And now the model is basically going to produce an explanation and an answer. The limitation of this, especially if you sample just once, is that like you're basically getting one possible reasoning path from a model instead of kind of aggregating over possible reasoning paths. And so self-consistency prompting is kind of a simple kind of approach, which basically involves sampling repeatedly from a model's decoder to generate a bunch of reasoning paths and possible answers, and then choosing or aggregating across multiple answers using a vote. So it's basically a kind of a simple way of doing something like tree of thought, which is kind of a more recent version of this. Another thing I want to give a bit of an overview of is prompt tuning, which is, in this case, we are not referring to prompt engineering. We're referring to like parameter efficient updates of certain model parameters, additional model parameters that you basically prepend to the tokens that you put into the model. And so you're basically learning these soft prompt vectors while keeping the rest of the model frozen. And by doing this, you can effectively update a large language model without training a large percentage of the parameters. Techniques like LoRa, if you guys are familiar, are also kind of similar in that they're also parameter efficient tuning techniques. And then we also talked briefly before about instruction tuning, but just to mention it again, broadly outside of the context of FlanPOM, again, it's basically given multiple tasks framed as instruction, task, and output. Can you fine tune a model to be able to do that? So in the future, when it sees an unseen instruction, which looks similar-ish to its previous instructions that it's seen, it's able to make predictions well there. And so just to give a bit of an overview of what we did to produce Med-PaLM, we basically took a set of questions that we worked with physicians to kind of get labels for, and we produced an instruction fine-tuning data set from that. And so this was a bunch of long-form consumer questions, and basically we worked with a panel of clinicians to produce a small set of example answers that the model could fine-tune on. And so the training examples basically look like what you see on the slide here. And then from there, we applied this technique we called instruction prompt tuning, which is just a simple combination of instruction tuning and prompt tuning, where you are applying the instruction tuning objective on the kind of the normal next word prediction objective on the context of instruction tuning data, but only on the prompt parameters, only on the soft prompt parameters. And so this is basically a way of taking a model like FlanPOM and better aligning it with the medical domain with relatively small amount of compute and with a relatively simple approach. And so in this context, FlanPOM itself was 540 billion parameters, but the prompt parameters that we initialized and then trained were just 1.8 million parameters. And so this is relatively low cost in terms of its in terms of our ability to train this. Any questions so far?
I had a question about like safeguards you guys have in place about sort of preventing hallucinations. So does this sort of like ensemble voting mechanism generally help with reducing these kinds of problems? Or like are there other metrics that you guys use to sort of prevent that or detect that even?
Yeah, absolutely. So by ensemble voting, you might be referring to self-consistency or ensemble refinement, which I'll discuss very soon. But in either case, broadly, yes, the models tend to get better performance in terms of their accuracy when we do that type of thing. It's also a bit expensive to apply in practice. And so when we generate answers to long-form questions and evaluate them with physicians, in that case, we are just generating once to kind of do that in kind of the most simple way. But in terms of measuring, I think the strongest way to measure it is basically the human evaluation that we did. And so I'll talk a little bit more about the human evaluation results. And some of them were directly around kind of alignment with scientific consensus, which is meant to measure hallucinations.
Awesome, thank you.
I had a
Cool.
couple of questions as well.
Yep.
For how big was the data set for this instruction tuning?
So initially, for this Med-PaLM paper, the data set was just about 60 questions, which was tiny. For the Med-PaLM 2 and Med-PaLM M data sets were significantly larger. So with Med-PaLM, we were basically trying to see whether we could, with a very, very small amount of data, train the model to be able to kind of, without really adding additional medical knowledge, because 60 questions isn't enough to do that, basically train the model to behave differently than it would otherwise. And so I basically view this as an approach for, rather than adding some new knowledge to the model, it's basically kind of better aligning its existing pre-trained knowledge to the task of consumer medical question answering across the axes that we care about.
That makes sense. I was also curious about the specialty breakdown of the questions. I know the point isn't to get it to include more medical information, but have you seen whether differences in the specialty of the questions, or questions from different medical specialties, affect downstream performance on USMLE or other benchmarking data sets?
It's a great question. We haven't done a disaggregated evaluation where we try to break it down into different specialties and see how the performance changes. But for the MMLU data set, it does kind of break it up into subtopics where we do report results for different subtopics. So things like anatomy or high school biology or whatever it is, the different tasks. So we do report those results. Those are relatively small data sets, so I don't think they're super informative in terms of the different results between different data sets. But I think it's an interesting question. I think it's something that it's something that I think I haven't seen a compelling version of. So I think it's something that would be useful. Broadly, we have seen recently, as we've been exploring more detailed and specialist questions that often Med-PaLM gets wrong, because we've been kind of deliberately exploring that more recently. The questions that generalist physicians are less likely to know, Med-PaLM is also less likely to know, which kind of makes sense. And so we're kind of recently been investing more in kind of working with specialist physicians across different tasks, and for specific questions, getting the feedback and the ratings from the specialist physicians. But we haven't done a careful breakdown by different specialties in terms of performance.
Thanks.
Awesome. Let's keep going. I'll kind of briefly talk a little bit about Med-PaLM 2 and Med-PaLM M as well, and then I'll present some results. So Med-PaLM 2 builds heavily on the PaLM 2 model. There was a bit of a technical report, which has actually a decent amount of useful information in there around how PaLM 2 improved upon PaLM. There were three kind of main points. The first is compute optimal scaling. So there's been a bunch of work kind of exploring scaling laws in the context of large language models and how should you scale compute versus data. A few works have found, and this work kind of replicated, that the scaling laws used in other papers or often that were not used at all were not as optimal as doing things in the chinchilla scaling laws framework. So this is kind of roughly using 20 tokens per parameter of the model. And so this work also saw that and also kind of did a similar thing in terms of applying compute optimal scaling. The second thing is kind of improved dataset mixture, especially with respect to multilinguality, which kind of significantly improved performance there. And then the last thing is a mixture of objectives type loss, similar to the UL2 work that came out, where instead of optimizing for just one objective, you're doing kind of a mixture, but you're still retaining the model's autoregressive capabilities. I'll just very briefly summarize key updates for Med-PaLM 2. So the Med-PaLM 2 builds on PaLM 2, applies similar kind of instruction tuning and prompting techniques as were used for Med-PaLM. We kind of used an expanded dataset mixture and tuned it. We applied this technique called ensemble refinement, which I'll spend a minute on. And then we've also improved human evaluation and adversarial testing. So on the right, on the bottom right, you can see this illustration of this ensemble refinement technique. which can be viewed as kind of like an extension of self-consistency, where you get Med-PaLM2 to produce multiple possible reasoning paths, and then instead of aggregating it over it via like a majority vote, like in self-consistency, you take that those different reasoning paths and have Med-PaLM2 aggregate over them itself, and so that it has the full context of the reasoning paths. As a result, it's able to provide kind of a better answer than it would otherwise. I'll also briefly touch on PaLM-E. So this is another work that came out that builds on PaLM. PaLM-E was kind of motivated by the fact that there's been kind of work on the vision domain as well that has involved kind of scaling up vision encoders, but so far that's not really been well tied to PaLM and these large language models, although there's been some work on visual language models. And so PaLM-E basically combines PaLM and vision transformers to produce a visual language model where basically the outputs of a visual, the vision transformer are then mapped into the space of the large language model. And you effectively get a large language model that's also able to take in images and potentially other inputs and then output language. And so this was originally supported in the context of robotics and embodiment in that context, but it's also effectively a visual language model that we can use in this context. And so Med-PaLM-M basically is PaLM-E simply instruction tuned on multi-med bench, the second benchmark that I presented, including the multimodal tasks. And so Med-PaLM-M is basically trained across tasks in dermatology and mammography, genomics, radiology, and medical textbooks and pathology. And the data used for training it is shown on the right. And I'll briefly talk about experiments that we did with Med-PaLM, Med-PaLM2, and Med-PaLM-M. So with Med-PaLM, so some highlights from the December 2022 paper. We basically saw that for this MedQA USMLE style task, which was of interest to folks, but we also wanted to move beyond. We saw this like significant increase in performance from previous models. We also saw that the model was able to produce answers to long-form answers, open-ended answers to consumer questions in a fairly compelling way. And so I'll talk a little bit more about each of these results. And so if we compare at the time of Med-PaLM, the state of the art, and also FlanPaLM, we saw that FlanPaLM by itself, before we did anything with Med-PaLM, was able to perform quite well across different data sets. We also saw that for the MMLU clinical topics, things like clinical knowledge or college biology or medical genetics, that FlanPaLM was outperforming the other models that we were comparing against. We saw this in interesting analysis when we did selective prediction, which is basically this task of seeing whether or not the model can encode its own confidence in its predictions. And so if we came up with a way of basically asking the model how uncertain it is, which was basically involving asking the model repeatedly to produce an answer to a question. And then if the answers varied across different generations, and then that was kind of considered uncertain, otherwise it wasn't uncertain. And so if we use this metric to tell the model when to defer, and then we ask the model to defer 10% of the time or 5% of the time, we saw that the accuracy increased. And so that's basically a signal that the model is able to encode its own uncertainty about its predictions before it makes a prediction. So that was a cool thing to see. We also kind of measured, like I discussed briefly before, we measured clinician evaluations across different long-form questions. And so when we measured agreement with scientific and clinical consensus, which is probably one of the most important axes because it's effectively measuring hallucination, we saw a significant gap between FlanPaLM and clinicians, and then Med-PaLM was able to mostly close that gap. When we looked at comprehension, retrieval, reasoning, again, in the medical question answering context, there was, again, broadly a gap between FlanPaLM and clinicians to start. And then that kind of motivated our work on Med-PaLM, where we saw that we were able to broadly close the gap or significantly reduce the gap across all these things. With FlanPaLM, we again saw a gap for incorrect or missing content. Interestingly, for Med-PaLM, and we also saw this for Med-PaLM 2, there was actually an increase in inappropriate and incorrect content, or there wasn't a solid decrease. And so I think that for us, this was basically a signal that these models, when they're asked to provide a detailed answer to a question, can still hallucinate significantly. And often that hallucination can snowball to become worse if the model is kind of conditioning on itself. And so I'll talk a little bit more about that as a limitation of some of the work we did. But I think for us, this revealed that there was a bit of a trade-off between length of answers and the inclusion of potentially incorrect content. And so what we observed is like Med-PaLM would often produce more detailed answers than Plan-PaLM, and more lengthy answers, and so it would have more opportunities to hallucinate. And so if we reduce that, we would have a reduction in the amount of hallucination or inappropriate and incorrect content. But there's a bit of a trade-off there because both the clinician and the lay users broadly prefer the more detailed answers. Another really important axis was the possible extent and likelihood of harm. And so there we saw that Plan-PaLM again had a big gap with clinicians, which is quite consequential. And again, that Med-PaLM was performing more similarly to clinicians. Lastly, we again saw a gap for this question around bias in the context of medical demographics, but Med-PaLM was able to, again, mostly close the gap. We also asked, again, lay users to basically rate whether or not they preferred Med-PaLM or Flan-PaLM or clinician answers. And in this case, we were asking about whether the answer addressed the intent of the question. We saw that there was a bit of an improvement between Med-PaLM and Flan-PaLM, but not super significant. And then in terms of helpfulness, we again saw a significant gap between Flan-PaLM and clinicians, and that Med-PaLM was able to mostly close the gap. And so that was promising. So that kind of summarized the key results for the Med-PaLM 1 paper. For Med-PaLM 2, we basically built on this again in the context of medical question answering, using kind of an improved model and provided kind of more improved methodology for doing evaluation, including kind of pairwise ratings between different possible answers, and adversarial testing in the context of both general medical questions and health equity questions. And so on the left, you can see, again, on the assembly style benchmark, that there's a significant improvement in performance. On the right, we basically asked physicians to choose whether they preferred Med-PaLM 2 answers versus physician answers across different axes. And so, for example, given a Med-PaLM 2 answer, given a physician answer, which one better reflects a scientific or clinical consensus? What we observed was that there was across 8 of 9 of the axes that we looked at, that Med-PaLM 2 answers were preferred by physicians over physician answers. But I want to caveat that with the statement that this is specific to how we did the evaluation and the collection of examples, and that Med-PaLM 2 was often producing significantly more detailed answers than physicians, which could cause like some bias in how people are doing these ratings. And we did observe that there was kind of more incorrect or inaccurate and irrelevant information in Med-PaLM 2 answers. So that was kind of suggestive of this trade-off between length and the potential for the model to include stuff that isn't really relevant. So just giving a brief overview, sorry the text is a bit small, of the medical multiple choice question results from this work. We broadly saw that Med-PaLM 2, the best results we were getting with Med-PaLM 2 were about comparable to GPT-4 and significantly better than Flan-PaLM or Med-PaLM. And we also saw that when we applied few-shot prompting versus chain of thought prompting versus ensemble refinement prompting, that ensemble refinement prompting broadly outperformed the rest. So Med-PaLM 2 also produced improved long-form answers to consumer medical questions, which was kind of one of the main motivations for the work. And so here's some examples of clinician answers and then Med-PaLM 2 answers, and then some of the ratings that clinicians gave those answers. We also did kind of a more detailed, thorough physician individual evaluation. Interestingly, this is kind of the first thing that we did, kind of more similar to what we did with Med-PaLM, where again, across these 12 axes that we were originally measuring, trying to see whether or not there was whether Med-PaLM was preferred over Med-PaLM2 was preferred over Med-PaLM and physicians. What we broadly observed was that this didn't have a ton of statistical power anymore, because across many of the axes, the performance for all three of these things, Med-PaLM2 and Med-PaLM and physicians, were quite high. And so that kind of motivated us to do pairwise evaluation instead, which I briefly talked about earlier. We did kind of evaluate on these adversarial questions. On the adversarial questions, there was kind of a clearer benefit for Med-PaLM2, even on this individual evaluation framework, where we just looked at one question, one answer. But if we looked at the pairwise evaluation, so again, this is one question and then two different answers, there was a significant benefit for Med-PaLM2 versus Med-PaLM or physicians. We also did a layperson individual evaluation. So this is for lay users, asking them whether they thought that the answer addresses the intent of the question or whether it was helpful. We broadly saw some small improvements for Med-PaLM2 versus Med-PaLM and physicians. Any questions up to this point? Okay, cool. I'll also touch a little bit on Med-PaLM key results. So on the left, we have a spider plot, which basically shows the state of the art across multiple different tasks here. So from mammography classification to radiology report summarization, we see the area in blue is basically the performance of Med-PaLM. So broadly, what we see is that Med-PaLM is able to kind of roughly match the specialized SOTA across many, many different tasks and approach state of the art there. On the right, we have kind of a more detailed comparison. So we can see that roughly across all these different types of tasks and across these different data sets, that one model, trained with the same weights, is able to perform roughly on par with the state of the art across many different tasks. Of course, there are cases in which the state of the art significantly beats Med-PaLM and vice versa. But broadly speaking, the kind of thing that we saw here was that this kind of idea of like a generalist model that could do multiple tasks seemed to have some weight. And another thing I wanted to mention is that these results were not like heavily tuned or anything like that. And so this was one set of weights, one attempt at model training, and fairly strong preliminary results there.
Do you mind going back? For the metrics, I had two questions. One was, could you explain the F1 rad graph metric?
Yeah, absolutely.
And then second, more generally, I'm curious how you think about, it's a similar question to what was asked before about the difference between benchmarks and real world data and how you evaluate these types of models and whether there are better metrics that capture more of the medical information, compared to just rouge, blue, and F1 scores, I guess.
Yeah, absolutely. I think accuracy and rouge and blue, I think are not the most useful metrics, but they're basically a way of getting a barometer of model performance, especially in like preliminary results. In the next slide, I'll also talk a little bit about the human evaluation results for Med-PaLM. But for the specific context question about F1 rad graph, I think in general in the radiology context, people often will report a couple things. One is these natural language generation metrics like rouge and blue and CIDR D. The second thing is kind of general accuracy metrics, where accuracy in this context comes from labels that come from some automated systems in some ways. So there's kind of a history of basically like Checkspert labelers or other kinds of labelers that basically take in a reference report and then produce a classification across different kinds of conditions. So given a reference report, basically classifying across different clinically relevant conditions, and then doing the same for the model generated report, and then measuring metrics like accuracy and F1 score and things like that. And so that's the kind of metric that F1 rad graph is. I'd say that metric or these kinds of metric are actually relatively relevant compared to kind of rouge and blue and other things, because they're aiming to extract the clinically relevant information from a chest X-ray report and then kind of framing it as a classification problem. That said, I think this is not enough for us to be able to say that these models are actually useful in real world workflows, because we need human evaluation, and then two, we actually need to put them in real world workflows. So for the first point, I'll talk a little bit about that on the next slide, but the second point I think is not addressed by this work.
So I had a question about if there's any like interpretability work done on some of the imaging or others, because like a lot of these data sets like mimic, even state-of-the-art classifiers have a proclivity to, like, if you look at their grad cams or whatever, to pick up on just auxiliary information that isn't relevant, but optimizes for classification. Was there any sort of like ablations or things tested to see if like the accuracy that you were getting on these was actually that and not auxiliary information?
Yeah, it's a really great point. I think the history of medical imaging has been like littered with um, models or evaluation approaches that often cause a model to kind of look at like shortcut features. So often, for example, you'll train a model on multiple tasks, and then it'll often get good at the task of hospital prediction versus prediction of the actual thing that you're trying to do. I think in this context, a couple ways we tried to mitigate this broadly. One is we tried to use a wide variety of data sets. And so that's not, I think, fully convincing, but it basically kind of creates a situation in which we were able to train and evaluate across many different contexts, across many different data sources. And so it reduces the potential for the model to be relying only on these kind of spurious correlations. The other thing is we did do some like human evaluation of the model's outputs. And so they're given actual chest x-rays, given model generated reports. We had the model basically, or had radiologists look at the actual explanations produced by the model and see whether or not they were preferred and whether they had significant errors or minor errors or things like that. And so that latter thing, I think, is probably the most convincing thing.
Gotcha.
Cool. I'll just briefly talk about the physician evaluation here. So we basically did a four-way comparison between reports produced by different sizes of Med-PaLM and a reference report from the dataset. So this is a radiologist-produced report. Broadly, what we saw was that the reference report was preferred over the model-produced reports in every case, but that the kind of pairwise preference between the strongest models and the strongest settings was often approaching 30 or 40%. So that that basically means that like roughly in 40% or 30% of the cases, that radiologists actually prefer the model-produced answer versus the radiologist-produced answer. So I think this kind of suggests like an early indication that these things could be useful in this real world workflow. But that said, this is like a very early result. The sample size is small. This is across just one data set. And so there's plenty of limitations here. Awesome. So I wanted to give a bit of time for discussion here, and I wanted this to be a little bit open-ended. So if we kind of jump kind of back and think about like the implications of this work, we have Med-PaLM, which kind of showed that these models encode clinical knowledge, that they're able to answer medical questions and perform kind of a wide variety of tasks that can be framed as a medical question. We have Med-PaLM 2 that kind of further improves that towards expert level performance and performs well on both multiple choice questions, and is also able to kind of produce answers that are often preferred by physicians over physician answers. And then we have Med-PaLM, which kind of significantly expands the set of tasks that we're doing with these models, often kind of classification or accuracy tasks, but also some generation or summarization tasks as well. And so now there's a significant amount of kind of tasks that these models can do. And across these works, we relied heavily on human evaluation to be able to validate these models on these specific tasks. And so if we go back to our initial dream of kind of improved care delivery and improved science, I'm curious what you guys think are kind of the main blockers for us to be able to actually achieve these things. I have a few things listed in the next slide, but I'm curious if anybody has anything that they want to raise.
Yeah,
Yeah, for the medical image, sorry, you go first.
Yeah, go ahead.
Okay, so one thing in medical images that or like common convolutional neural network are not handled well It's different data set, different medical image data set, different modality, they have different resolution or different size of the images. But sometimes the size or the dimension of the images could be informative. Like you have a bigger cell, you have bigger tumor, that could be an issue. So I'm wondering in this image encoder that you fit into the vision long range model, would you also consider the dimension of the images?
Yeah, absolutely. I think that was definitely a limitation of our work with Med-PaLM. The resolution of the images that we were feeding into the model was quite small, and so broadly, we suspect that was one reason that the model's performance didn't really scale a ton with improved model scale. In general, there is kind of a wide variety of resolutions of images that show up in medical imaging, and there's also like 3D images, like CT scans, like volumetric scans. There's also potentially gigapixel images in pathology, and so I think that, from my perspective, kind of motivates work on kind of being able to train different encoders for different kinds of modalities, and being able to kind of graph that onto large language models without retraining the whole thing. Or an alternative approach might be training encoders that are more universal, that are able to take in all these different kind of resolutions of images. And so there's work around kind of transformers that can take in raw bytes, for example, sequences of raw bytes. I haven't seen them applied kind of broadly in this context, in the context of multiple different medical modalities, but that I think would be quite interesting.
An easy way I can think of is you just add a type. Like if you're a doctor, you look at the images, you know its resolution or what kind of images it is. Or like in this way, I feel like you don't have to retrain your model and you can have universal model, but also with reference to the like information doctrinal.
It's true. It's true. Like you can annotate it with the tasks that you care about, and that's definitely instruction tuning gives you that. But there's also a potential that like you might be losing information if you downsize, for example, a gigapixel image to a much smaller resolution. And there's also the issue of how to handle volumetric scans and things like that. And so it might, I think putting everything in a vision transformer might not be the approach that ends up working out.
Mm-hmm. Yeah, makes great sense.
Mm-hmm. Building off of that, one thing that came to mind, or I had two interesting things. So there was a paper published like from Oxford a while back on when using transformers on images, like medical images, like brain scans and stuff, that like diffeomorphisms and morphological preservations, when actually, convolving features are actually attempting to learn from them, actually like smooths over features inadvertently. And that actually removes a lot of information in a lot of ways. And I was wondering, like, I think something that a lot of people have put effort into is preserving morphological structure, well, like convolving features, or even with like vision transformers like VIT, they still use some sort of encoding representation that has a proclivity to lose that like underlying like isomorphisms and diffeomorphisms from like MRIs. And that's like difficult to keep track of. I don't know if like preserving structure, I think we talked a little bit about like structure from different modalities and images is like something that's possible, like considering the variety.
Yeah, I think our choice of architectures and loss functions often encodes kind of inductive biases about the problems that we're trying to solve. And in the case of convolutions, I think that's clearly true. Another one that's relevant to our work is around self-supervised learning. If you apply like off-the-shelf approaches like SimClear, you will effectively, your augmentations will involve throwing away a lot of information that's contained in medical images. But those augmentations are basically encoding inductive priors that work well for ImageNet. But in the case of medical images, your loss can throw away quite important information. And so I think it does make sense to kind of think about what inductive biases these approaches are encoding, and like what that has to do with the medical setting. Because I think if we don't explicitly think about that, then we might effectively train models that are less reliable or relying on the wrong features and things like that.
Yeah, and the other thing is that like, so I'm at like MIT, like MGH and HMS. So there's a lot of like clinical applications of AI that we end up using here. But a large conversation that we have is the sort of workflows that we have in, highly resource enriched environments in hospitals is not that of what's available in different areas that are more resource constrained. So like AI suggests clinical workflows or things might be more difficult. Are there like considerations that you guys have when working with stuff like PaLM 2 that the not only the data but also the workflows themselves are better adapted to resource constrained areas?
Sorry, I didn't understand the last part of the question.
Oh yeah. So is it like, so the workflows that we have at, like a hospital like MGH are not equivalent to that in more emergent countries. So like the clinical suggestions and practices of techniques or like interventional suggestions that a model might have trained on data from these like research enriched areas like MGH or something.
Yeah.
How well does it translate for a model like Med-PaLM when it provides suggestions on like practices or clinical suggestions for places that may not necessarily have the same resources?
Oh, it's a great question. It's something that we're looking at now. Broadly, what we see is that, as you'd expect, performance might not be quite as good, and it's something that like we are actively looking to mitigate.
Cool.
I think along those lines. Oh, sorry.
Oh, no, go for it.
I think along those lines, how do you think about capturing either information from missing data or just handling, data that you might not want to include, right? So, suppose you have imaging data for a patient, but it's not necessarily relevant, or it's, there are artifacts in it that are actively working against the model. Are there ways to mitigate that or be able to identify situations where you might not want to use that data?
Yeah, it's a great question. So in cases where data might not be super useful or might basically cause the model to reinforce the model's reliance on spurious correlations, how do we make sure that we're not relying on that data? It's a great question. I think to this point we're kind of largely relying on whatever data we can or is available, because I think in a lot of contexts, medical data that's de-anonymized and everything like that is hard to come by. But I think there's kind of work on kind of trying to develop classifiers for whether or not data contains spurious correlations, if that makes sense. So people will often do things where they will train a model on data from one data set. They'll look at its predictions on another data set that's out of distribution, then look at additional labels that come in for that data set, and then try to train a model that excludes the examples from the original data set that caused it to reinforce unspurious labels, if that makes sense. So it's kind of approaches that people have for mitigating this, but we haven't really applied this in this work.
Yeah, it's interesting to hear more about this because I don't do vision language models. I'm much more on the clinical note side. Thanks.
Awesome. So I just wanted to quickly mention there's a couple more discussions around limitations and open challenges here. Wanted to kind of quickly mention that this work would not have been possible without this large team of people, and so very appreciative of everybody and my scientific soulmates shown on this slide. Thank you.
Thank you so much, Karan. That was an amazing talk. I think we didn't have time yet to talk about like the care delivery part of it and like how you envision this model be actually embedded in a workflow, given that it was trained on like very high quality question answering style data set. Like, what do you think data from practice would add, like data from clinical notes that would be missing in such a data set?
Yeah, I think the thing that I think is kind of a big next step is really thinking about evaluation in the context of specific clinical workflows, and then thinking about what data is useful for those specific workflows. And so one thing that I think is starting to happen is there's a lot of work around taking large language models and using them to reduce the burden of clinical care. So things like documenting an interaction and things like that. People are often spending hours a day doing things like that. In that context, I think the data that companies in the space are collecting around transcriptions, the summarizations of those transcriptions, any labels that doctors have around the quality of those transcriptions. So, for example, if I'm providing a service for reducing the burden of clinical documentation that involves taking a transcription and then summarizing that into a clinical note or a discharge summary or whatever it is. If I have feedback data, which is basically looks like whether clinicians accept or decline, that recommendation for a possible generation, I think that's probably the most useful kind of data for that kind of use case. Yeah. That's kind of what's roughly missing, because like we're at a point where I think the large language model based capabilities and knowledge are roughly good enough to be able to do that task. And I think the thing that's needed now is kind of like refinement on kind of feedback on that specific workflow. And I'd say the same for other workflows, like if we're talking about clinical decision support, which I think is a really exciting use case as well. I think roughly speaking, the models have a good amount of knowledge here already. I think ideally we could fine tune on additional data that comes in from the clinical context. But then probably the best thing there would also be additional feedback data, which looks like in the specific context that a doctor is operating in, given the specific populations and distribution of patients that they're looking at, whether or not they accept the predictions of a clinical decision support agent. In general, I think that's kind of where we're at. Where I think that the missing piece now is the post-training refinement of these models in the context of specific workflows versus like the pre-training, which is I think already quite capable.
So, do models like this have an ability for federated learning or methods where, like, essentially, there was a lot of case studies done about a classifier model they built on predicting, sepsis from different sets of Mount Sinai hospitals. And if you looked at the features from a couple of branches, they were completely different, and like your race and your ethnicity mattered substantially more. And then if you looked at more like a different set, it was actually like clinical factors like albumin levels or whatever. So is there some sort of method of training these models? Like when you talk about, catering to specific clinical workflows of sort of adjusting for a variety of different of clinical settings?
Yeah, absolutely. So on the context of federated learning, it's in theory, it's quite, I think, well motivated in this setting, because you are effectively, getting the opportunity to, in a private way, train on data from different contexts and condition on data from different contexts, and use that to improve a model. And privacy is often a big concern when it comes to PHI and health data, and so it's quite well motivated. I think there's kind of a significant challenge, though, to scaling federated learning to the scale of language models, which remains. So the communication costs and efficiency, memory and bandwidth costs of doing this,
right,
can often be relatively hard, unmanageable. That said, like I think parameter efficient techniques and exploring this in the context of cross silo settings like hospitals can make these things more manageable versus like fully cross-device federated learning, where you have to send a large language model to each person's device every time. And so that's one thing. On the technical level, in terms of getting models to be able to condition to different contexts, I think this is basically a function, I think, of training on a lot of diverse data with instructions for the most part. I think like there's this is effectively kind of what was shown by the instruction tuning paper outside of the medical context, that if you train a model to follow instructions broadly across a wide variety of tasks and have it do a wide variety of tasks during training, that during tests it can kind of generalize to somewhat unseen tasks. I think we've seen a similar kind of thing in a medical setting with respect to training, and so that training objective can also be applied in a federated learning context.
Cool.
Okay, I think we are 10 minutes way on top of the hour. So thank you so much, Karan, for this great talk and this great work. And thanks everyone for joining us.